liver disease, how we use shear wave elastography as a technique and how we can get the most out of it as an imaging tool. We need to gain an awareness not only of patient limitations, but also what obstacles may be placed in front of us due to the patient's presenting symptoms or equipment or disease process. And then again, how we actually use shear wave in clinical practice. So chronic liver disease, in essence, is any process affecting the liver that extends for longer than 6 months. We know that most people think of chronic liver disease as our viral infections, Hep B or Hep C. And in Australia, there's around 500,000 people who live with Hep B or Hep C. But internationally, those numbers are 540 million. In Australia, though, one of the leading issues of premature death is not Hep C or Hep B, but alcoholic liver disease. And unfortunately, we have about 8,000 deaths a year that occur as a result. Alcoholic liver disease is a micronodular cirrhosis, so it leads to irregularities of around 1/2 to a centimetre, whereas the hepatitic or the viral chronic liver diseases lead to macronodular cirrhosis, which means nodules of over a centimetre. There's a big shift in the amount of liver disease we're seeing internationally, and that is because of non-alcoholic fatty liver disease, or should I say internationally in developed countries. So there's an estimation that non-alcoholic fatty liver disease actually affects about 30% of all adults in developed countries, as opposed to only 2% in Southeast Asia. The other thing about non-alcoholic fatty liver disease is that particularly in patients who are insulin resistant, they have a high risk of going on to develop cirrhosis. But interestingly enough, the rates of going on to develop HCC are actually much lower than Hep B and Hep C, and we'll discuss those later on. Irrespective of the type of chronic liver disease you may acquire, the mechanism for disrupting the hepatic architecture is the same. You get an abnormal increase in collagen deposition and other components of the extracellular matrix in response to chronic injury. As this injury progresses, you get scar tissue and fibrosis, and as fibrosis progresses, you get cirrhosis. And unfortunately, with cirrhosis, you can get portal hypertension, liver failure, or HCC. All of these processes basically result in a normal, pliable liver becoming stiffer. And this is one of the basic principles that we need to keep in mind as we talk this evening. So the ability for a doctor to know if and subsequently what degree of fibrosis is present in the patient's liver will indicate the course of the chronic liver disease in question. So we talk about, have we got fibrosis or have we got cirrhosis? And the most commonly used scale is the Vir Score. So we talk about people having an F0 to 1, which is just normal liver or only mild fibrosis, F2, which is significant fibrosis, F3, advanced fibrosis, and then F4, which is the irreversible cirrhotic stage. So what levels do we care about? Well, there's a number of different platforms or standards that have been set. Certainly, most of the European and Latin American countries worry about patients who have got viral hepatitis as having a fibrosis score of greater than 2 or cirrhosis. If patients have non-alcoholic fatty liver disease or other chronic liver diseases like primary sclerosis, sclerosing cholangitis, we worry about when they've progressed to cirrhosis. In Australia, we've had a recent set of guidelines where we know that all patients who have hepatitis C are eligible for treatment irrespective of the fibrosis score they have. However, we know that what really matters is if they have a score of greater than 3 or greater than F4, because that will influence the treatment duration and the regimen. So in our state, in Australia, as long as you have longer than 12 months to live, you are eligible for the retroviral medication. A lot of people say to us, well, don't you know if someone has cirrhosis? But interestingly enough, compensated cirrhosis can be clinically silent in up to 40% of patients. So out there in the community, up to 40% of patients with compensated cirrhosis won't have a diagnosable form of it until they come and see us. And it's really important for us to know whether a patient with chronic liver disease also has portal hypertension, and we'll speak about that as well. So how do we currently score liver disease? Well, the gold standard has always been the use of a biopsy. But as you can see here on the screen, biopsies not only carry a high complication rate, but you can get varied results depending on which part of the liver you sample. So as you can see here, if you put a needle into point 1, you would get a high score or a cirrhotic score. But if you put a needle into point 2, you might get a series of regenerated liver or normal liver. And that's why we decided that we needed, or the profession decided in 2008, that a non-invasive test was required. And this led to the development of elastography. Now, as Claire said, elastography is the way that we measure tissue response to a stress, and we can do that with ultrasound or MR. And it's really the transverse wave. So if you push a jelly mold, how it wobbles from side to side. So this is transverse or shear waves. It's the same term. And there are 4 ways that we can assess how stiff the liver is with elastography. The first one is the Fibrous Scan method, which people commonly call TE or transient elastography, the point shear wave, and the next 2, either 2D shear wave, which is what we use, or MR elastography. Now, we're not going to spend a lot of time this evening talking about MR elastography because that's something that we don't routinely do as sonographers. But I think it's important that people realise that people do have MR elastography. It's an important tool. It's basically driven by a driver that sits under the patient. And the reason that physicians like it is because liver cirrhosis is a geographical disease, and it affects the liver in different ways and certainly different segments. So with MR, you get an opportunity to look at all of the liver, so that if you're only sampling a bit where there's regeneration, you get to see what the other areas are doing. And importantly, as you can see here, you get to have a look at the spleen. But that's something that we can do as well, and we'll talk about that in a moment. So currently, when a patient comes to a hospital for assessment of their fibrosis, the gold standard is considered a Fibrous Scan unit. And Fibrous Scan elastography is something that's done by gastroenterologists, often in their practices. And it involves a blind technique, as you can see here in the bottom picture. I don't know why they've got a picture of the left-sided of the patient, but this is on the Fibrous Scan site. And what happens is this probe gets pushed into the patient's side, and about 4 centimetres from the face of this probe, a measurement is produced by the machine. The machine actually produces 10 measurements, and once it measures the elastography, it produces a KPA value. The practice nurse then looks at this KPA value that's produced, which is down here, reads along the chart, looks at what presenting disease the patient has come in with, and decides what fibrosis score the patient has by looking on the side. So if we have a blind technique that's doing so well, why did we have to introduce shear wave elastography? Well, there's a number of reasons, but we'll go through some of the more obvious ones. So, first of all, we introduced point shear wave, where we were able to direct a box into the liver. And this is what point shear wave looks like. And the same way, a Fibrous Scan gives you 10 measurements. This, you just repeat measurements until you get the 10. Other manufacturers then came up with 2D shear wave, and this is what we use here at Fiona Stanley. So we have two vendors, and we basically introduced this technique to match the Fibrous Scan. So again, why would you use 2D shear wave when you have a Fibrous Scan service? Well, it starts with looking at the World Health Organization recommendation, and they said that shear wave elastography should not be used in isolation. It should always be a part of a good diagnostic workup. So anamnesis, which is a taking of patient history and patient palpation, blood tests, and then moving on to non-invasive methods. For example, Fibrous Scan, or as SEAT's recommended, we should always do shear wave with a detailed B-mode image study and Doppler. And I think this is key, that we have to remember shear wave should never be done in isolation. And unfortunately, when you're using a Fibrous Scan, which is a blind technique, it is an isolated method. And that's why all of the manufacturers are looking to refine the technique. We always do it in with other techniques, and that's why this is our observation sheet that I'm happy for other people to obtain from Toshiba and use freely in their practices. We ask what the presenting chronic liver disease is. We indicate if there's a technically appropriate examination. We look at a number of factors within the liver, and then we perform an elastogram. So you can see here we fill it out, we put in what value we get, and then we correspond it to a Vir Score. Now, the ability to do a good ultrasound of the abdomen is not undermined in the literature. And the most recent WFAM consensus was that even if you have never done elastography, if you've done more than 300 abdominal scans, you can do a good elastogram because you understand the anatomy of the liver, and therefore you will place the elastography sampling region of interest in the correct area. Another advantage of 2D shear wave over the Fibrous Scan is that it's not blind. You can get a region of interest, drop it into the liver at an appropriate depth, and do not just one but multiple samples. You can change the field of view knowing the physics behind 2D shear wave. You can change your regions of interest. You can make them small or large to avoid vessels, multiple measurements. And then this is really probably one of the most important factors, is that we can measure in either meters per second, which is a true shear wave value, or an elasticity coefficient, which is kPa. Now, we get asked quite regularly, do we report in meters per second or kPa? Well, we're fortunate with most manufacturers, you can get both sets of data. But at the moment, people are looking at whether we should be using kPa at all. So we've always used kilopascals because that's what the blind technique, a Fibrous Scan, produced. But the quality assurance people are saying to make a meters per second into a kPa, you need to apply a formula, and there are assumptions that have to happen with that formula. So, I mean, at the moment, I suppose we could say watch this space, but it might be that most of our future measurements are going to be reported in meters per second rather than kPa. One other advantage of using, obviously, a visualized segment over the Fibrous Scan is that we can use it on obese patients. So if you look at this transverse section of the abdomen of this patient on the CT, if they had a Fibrous Scan, well, they'd actually be getting an elastogram of the fat. So we can guide our sample volume. With Fibrous Scan, they can get up to a 25% failure rate, whereas with 2D Shear Wave, we have less than 10%. The other thing is that we can use it in patients with ascites, and we get multiple patients that come through our hospital who have had failed Fibrous Scans that we are able to do measurements on because we can optimize our window through narrow intercostal spaces and get an elastogram. With the Fibrous Scan as well, you need to get 10 recordings and the machine automatically generates them, and even with 2D point shear wave, you need 10 recordings, whereas the World Federation have said that with 2D shear wave, you only need the mean of 4 values. And in fact, recently they've come out with a new guideline that hasn't been published yet, unfortunately, where they are recommending that you can do the median of 3 values, as long as your standard deviation is less than 20%. Claire spoke last week about the quality indicators that you get when you do elastography with 2D shear wave as opposed to the blind technique, and we routinely use those quite often, or all the time actually, in our teaching hospital setting. So the fact that we've got 2 lots of quality indicators, we've got our elastogram and we have our propagation map. Now, people get a little bit confused because they think that if the map are perfectly parallel, perfectly straight lines, it means a good quality elastogram. But if you think about it, as we can see illustrated in this image below, or these 2 images, when you push your pulse along and it hits an irregular bit of tissue or a stiffened bit of tissue, your lines are going to change because the geometry of what you're sampling changes. So it doesn't matter if you have lines that are at angles as long as they're parallel. So you can see these are all parallel lines, and they've obviously widened out as it's gone through the stiffer tissue. A recent paper that looked at 270 patients said if you get a stable elastography map for around 3 seconds in continuous mode, which is something we use on our Toshiba regularly, you can be assured that that's a good quality map and you can freeze it and measure off it. These quality indicators should guide us sufficiently so that, unlike Fibrous Scan, where authors say you need to do at least 500 cases before you get competent, with 2D shear wave, you really should be able to work autonomously and competently after only doing 50 cases. So when you look at our gold standard compared to shear wave, many studies have shown that we are actually better when it comes to diagnosing stages of fibrosis equal to or above F2. So for F2, F3 and F4, we are better than the blind technique. Not only that, but when you use the 2D shear wave, which is what we use on both of our vendors and in particular Toshiba, we have increased accuracy compared to the point shear wave for F3 and above. Okay, so it sounds like we've got a great tool that we can use on our machine, but just like other tools like our colour Doppler or pulse Doppler or any other tool really, we need to know that there are limitations and we need to take these into account when we're using it. So we're just going to spend a few minutes talking about the different sources of variability and what you need to be careful of when you're using it. So one of the most interesting things about shear wave elastography in ultrasound at the moment is that each manufacturer will produce a different number. And this was something that was quite difficult for us because we were really trying to rank two different vendors against Fibrous Scan. But there is no standardization across the manufacturers in how a shear wave is produced. As a result, we came up with this table. So as you know, all of the published work at the moment of all the verified work in shear wave is in hepatitis C patients with ultrasound. And so we came up with this table where we were able to compare what the numbers would be for each manufacturer and in fact across units. So you can see here we've got two Philips units, same manufacturer but different units producing different numbers for the same fibrosis scores. So that's something we need to be quite careful of. The other thing, just bear in mind, if you get a patient that comes to you and they say, oh, I had an elastography number of 7 on my Fibro scan, and you look across and you're using a Toshiba and you go, oh, well, 7 is actually F2. It isn't on the Fibro scan. So your numbers matter depending on what elastography unit you are using. Another thing you need to look at is what transducer you are using. So although systems, we have found that, the Toshiba systems are quite good going from a linear to a curved probe, in effect, Wolfram said you basically shouldn't do this. If you're using ultrasound for the liver, you should be using the convex probe. If you're using ultrasound for superficial parts, you should be using the linear probe. And that's what their recommendation is. And quite honestly, we have strayed away from using the linear probe anyway for livers because rarely do you get a great result, and that would be our recommendation. So abdo probe for livers, even if it's a thin patient, use the abdo probe. One of the things you need to keep in mind when you're using shear wave is that to generate a shear wave, you need to have a really low frequency, which means that you have a really big, thick beam. And so when you're looking through a patient, you can see that here we are, we've got a thick beam, and as it goes through a thick bit of ascites, we get a straight propagation map. But look down the bottom here. How can you get an elastogram or a wiggly map through fluid? Well, obviously because either side of this region of interest is solid tissue or bowel or an interface. So keep in mind that what you are looking at when you're using your shear wave is not necessarily what's in your field of view. And I think this is one of the biggest sources of variability within a liver. We always ask our patients to fast, but unfortunately it's not always possible that people abstain from alcohol, especially as outpatients. So we just ask patients to fast for 3 hours as outpatients to reduce the level of metabolic activity, because any metabolic activity, be it digestion or smoking, will artificially increase your shear wave, as will exercise. I have to say in our patient group there aren't too many of them coming in active wear, so that's not a consideration for us, but the World Federation for Ultrasound in Medicine and Biology have done studies that show you need to have a good 10 to 20 minute rest before you do a shear wave. We tried to adapt a Fibrous Scan technique where the patient was on their back or rolled up, right arm above their head. We tried to use intercostal spaces with, and sort of, rotate the legs away. But ideally we found the best way to do elastography was with the patient supine, not rolled up, having the arm just crossed across the chest, and again using intercostal spaces 7 or 8, and not being too anterior and keeping the patient relaxed. Now, Paula King, who's an amazing sonographer who does a lot of elastography at Royal Melbourne, reinforced this, that a relaxed patient is the best type of patient to do elastography on. So as a result, we don't get the patient to forcibly inspire or expire during a scan. We try and do a nice relaxed elastogram, and you can see here that just by getting this patient to take an inspiration, a big breath in, we get a difference of 4.9 to 7 kilopascals. And this is where using the continuous mode on the Toshiba helps, because you really often can let the patient just gently respirate through the scan, and then you can watch the map. And as I said, as this Teal's study found, if you can watch an elastogram consistently for 3 seconds and it's homogeneous, you can use it for an elastography assessment. The depth at which the elastography region of interest is placed also impacts. And again, one of the most recent papers found that if you have, with a convex probe, a depth of 4 centimetres, you will get your lowest variability. So try to keep your sweet spot about 4 centimetres from the probe face. There are other issues. For example, males have been found to have higher shear wave values for the same fibrosis scores. Older patients tend to have rigid intercostal spaces, and they tend to have higher patients. Higher BMI patients can also be a problem, and that's usually because the penetration of getting through these larger patients is an issue. And again, as I said earlier, we get quite a few patients with narrow intercostal spaces where a fibro scan can't be performed, but we're able to direct it. And occasionally there are patients who, just like colour Doppler, just like other imaging tools, are just not suitable for elastography, particularly those with laboured respiration. And on those you have to say, I've got too high a standard deviation. It's always consistently above 20%, and I really just can't get a good elastogram. Some of the sonographers that have contacted us after we started doing a lot of this elastography said that they had been told to measure a whole lot of different parts of the liver and then even out the score. Now, that's not appropriate. The left lobe of the liver always has higher shear wave values than the right because of the heart. And the bottom line is we are trying to produce an elastogram in an area where you would traditionally do a liver biopsy. So that is intercostal spaces 7 and 8. And this has been shown in practice to produce a much reliable, reproducible shear wave value than going too high or coming too low and anterior. The other thing, because of the slice thickness, again, you have to remember you need to avoid vessels, avoid the gallbladder, stay away from the liver capsule or any boundaries at all, because as soon as you get refraction, you're going to bend the shear wave as well, and you're going to end up with variable numbers. Be careful when you're looking at 7 and 8 in patients that have low lungs. You can see here that we've got this interference from lung. So we've got an appropriate elastogram here, but you would need to bring in your region of interest so that you didn't take into account those artifacts occurring on the edge. You can actually introduce an artificial shear wave increase by pressing too hard on the patient, and here you can see that this is due to pressure or the capsule. Now, this isn't so much of an issue because, as authors say, you just move your region of interest out of the red area. But to avoid this, ideally you should always be at least 1 centimetre from the hepatic edge. Now again, if you are using colour Doppler, we know that even on the technically challenging patients, if we can optimise our B mode image, our shear wave image is going to be optimised as well. So try to get the very best image you can in B mode before you attempt a shear wave, because Again, wide slice thickness often means that even if you can see the parenchyma in that really narrow window, your shear wave is going to be taken into account. Stiffnesses in the elevation plane that are not in view, that are difficult to assess. One of the techniques we use here is we always try to keep the liver capsule perpendicular to the oncoming beam. So here you can see a straight capsule, and we invariably get much better results and less variability than when we have an angled liver edge. So as we said, we know your sweet spot for elastography is almost always at 4 centimetres. You keep a straight capsule, free of vessels, free of artifact, and that's when you'll get your minimal variation. So after a lot of experimentation and looking at a lot of these factors, we found that these were really our top priorities for gaining a good 2D shear wave. We asked if the patient could abstain from alcohol or food. Patient was relaxed. We tried to keep the patient supine, keep the arm not extended too high, across the chest preferably, because high often means that you stiffen up the intercostal spaces. You don't want to have anything like that. We have an intercostal space of 7 to 8, shallow respiration, good B mode image, always at least 10 to 15 millimetres below the capsule, and keep this 4 centimetre sweet spot. And as we said, aim for 4 measurements, but in fact 3 measurements with a standard deviation of less than 20% fits the current Wolfram guideline. Okay, so what about patients? How do they vary? You've got a nice relaxed patient, but you're not getting or shouldn't be doing a shear wave. One of the most important things is patients that have deranged LFTs, cruise cirrhosis are not always patients for shear wave. So patients that have congestive heart failure, they will always have high shear wave values because they've got a congested liver, and the edema will increase your shear wave even though they don't have an underlying fibrotic or cirrhotic liver. The same goes for inflammatory or acute hepatitis. Cholestasis, again, you end up with an engorged liver, anyone who's eaten, and this is really what you have to be aware of, a transaminase flare. This is something that we get in hepatitis B patients. If they suddenly have a spike in their ALT more than 5 times the normal, and they do get that, you cannot do shear wave. As a result, on our shear wave chart, we've got all of this listed at the bottom. So when we look at what our reference number is, we keep this all in mind, that we cannot use it in patients who have acute hepatitis, transaminase flares, congestive heart disease, cholestasis, or have eaten. And this is something we need to remember all the time. A tense, inflamed liver or a congested, swollen, edematous liver, you cannot do elastography on. The other thing is what we've learned from our Fibrous Scan colleagues is that the levels vary depending on what sort of presenting patient you have. So as we know at the moment, 2D shear wave, which is what we use, has been validated in hepatitis C, but it hasn't been validated yet in other areas, only because there's been very promising studies in all of these, but we just don't have the data yet. But what we know is that in some patients, the numbers all vary depending on the disease process. So you need to find out not only what they're presenting with, but unfortunately if you've actually got multiple presentations. So for example, we have had patients here that have had hepatitis B, C, and alcohol disease. So it confounds your measurement, and you need to be aware of that. So let's have a look at some of our clinical presentations. With hepatitis C, both 2D and point shear wave have been shown that they're really good at diagnosing if patients have low levels of fibrosis or if they have F3, 4 and above. And we're very good with cirrhosis. One of the things, though, that we keep in mind here is that patients that have hepatitis C have the highest of all the groups of HCC rates. So we need to do a detailed B-mode study. There's been studies that have shown that we can assess patients post-treatment, so post-hepatitis C treatment or post-retroviral treatments, and there's been some good papers published. But at the moment, and we've got an example here, we've got a patient that had a 16 kilopascal elastography value before their treatment, and then afterwards, when we scan them, this reduced to 11. But WFM don't recommend us currently to use shear wave to monitor treatment response because it's thought to not always reflect viral load. Hepatitis B, as we said, this is one group where we're always mindful of have they had a transaminase flare, but irrespective, we've had some really good results to rule out fibrosis, and these are certainly probably one of our easier groups of patients because the progression to fibrosis is actually much lower in the hepatitis B patients, but again, we don't use it to monitor treatment, and we really, again, do a very detailed HCC screen, especially in hepatitis B patients, because unlike alcoholic liver disease and hepatitis C, hepatitis B patients will often develop a HCC without going through to the cirrhotic stage because of the genome of Hep B. There's been a lot of reports about the high failure rates of shear wave when examining high BMI or, big sort of turtle-like abdomen patients. And in fibrous scans, there's been some very conflicting results. Some papers say that if you have non-alcoholic fatty liver disease, your shear waves increase. Other people say that they go down. The jury is still out on all of this, and certainly we have found that the papers so far show that we are better using point shear wave or 2D shear wave in diagnosing fibrosis in non-alcoholic fatty liver disease patients. So it's something that we're trying to gather data on. The difficulty with the reduced shear waves in non-alcoholic fatty liver disease is there's a bit of controversy as to whether if you have just plain old non-alcoholic fatty liver disease, so a squishy fatty liver, whether your numbers are low because it's almost like pushing the top of a pate. It's just fat, it's a bit squishy and nothing else is going on. But when you get patients with non-alcoholic fatty liver disease and we get high shear waves, the question is it because we've got an inflammatory change? So are we actually seeing the non-alcoholic fatty liver disease patients progressing to non-alcoholic steatotic hepatitis? And that is why we have to be very careful to have a look at these patients, look at what their ALTs are doing and make sure that they're not having a flare-up. And therefore we're dealing with like a acute hepatitis rather than just plain old fatty liver disease. There was quite a large study that came out in 2010 that suggested that if you've got a patient with non-alcoholic fatty liver disease, this squishy number of greater than 9.3 is indicative of cirrhosis in the liver, whereas in a patient with hepatitis C, we would only think that that was a mild fibrosis. There's been some work being undertaken in using shear wave as a role in obese children to assess if patients do or don't have a fatty liver. And you can see here, here's a highly attenuating liver in an 8-year-old boy. So a 2017 study showed that if you get higher levels in obese children, then you've got non-alcoholic fatty liver disease, obviously, as opposed to the lower levels in the pediatric liver. So they were using meters per second, and they decided that anything above 1.4 meant that the children had non-alcoholic fatty liver disease. We found that patients with alcoholic fatty liver disease have much higher shear wave values for cirrhosis than our patients that have HCV. And there's a thought process in a study by Teal that said that because when you have alcoholic liver disease fibrosis, you get scarring around the venules, so around the vessels, as opposed to around the actual cell, which is what you get with HCV, that you get much higher levels. When Teal looked at these 206 cases, they found that almost all of the cirrhotic livers were more than 16.5 kilopascals. And as we know, our greater level, our F4 for cirrhosis in our other liver diseases are around the 11 mark. Wolfram thought that although we could use shear wave in alcoholic liver disease, because of the inflammatory, the acute hepatitis that occurs within that spectrum, you just have to be careful that you're not getting someone when they're having an acute flare-up. And they were able to show that when you do have abstinence in patients with alcoholic liver disease, you get a reduction in the shear wave. And they're not sure if it's due to normalisation of blood or the alcohol-induced hepatitis, or whether it's actually a reflection of changes in the liver stiffness. One of the most challenging uses for shear wave is really in the ability to predict portal hypertension. So we know that when a patient has portal hypertension, it really impacts on the patient's ability to have a good prognostic outcome because of the development of varices and other things. So people would like us to be able to replace annual endoscopic review of patients' varices with a non-invasive test. And rather than the liver shear wave being a source of a predictor of portal hypertension, people have found that spleen shear waves are superior in predicting sensitivity and specificity of portal hypertension than the liver. So Ferrucci found that if you had a liver shear wave value of greater than 25 and a splenic shear wave value of greater than 28, you actually had a sensitivity of 89% and a specificity of 92% to rule in clinically significant portal hypertension. And here is a good example that we have got in our department. You can see this gentleman with known portal hypertension had levels, shear waves of well over 25 in the liver, and in the spleen, 64. And this is interesting. So as we know, we put in transjugular portosystemic shunts in patients to decompress liver to release portal hypertension. And this is an interesting case that we had in the department where you could see before the TIPS shunt, the spleen had an elastography value of 30, and then after the shunt, an elastography value of 16. As I said, we found at Fiona Stanley quite quickly that our alcoholic liver disease patients had really high numbers when they were cirrhotic compared to what our cut-off point was. And although, you know, people often talk about F4 being greater than 11, we found that our median was around 30. So again, we think this is a reflection of the fact that a lot of our alcoholic liver disease patients have portal hypertension as well, and it's something that we're looking at closely in our future work. Okay, so back to our standard fibrosis classification. So how have we found those? Well, we think that our experience in diagnosing F0, F1, so less than 6.6 kilopascals, has actually been really good. And we're quite confident we get good elastograms in these groups and nice low numbers. And we're quite confident in these patients that we get a nice B mode and a corresponding elastogram. And they're quite reproducible, and we don't have much issue attaining them at all. When we're getting into the F2 or, like some progression of fibrosis, we find that we're now seeing the subtle B mode differences that go with it. And this is our advice, that when you see a subtle change in the B mode, you think, oh, is this elastogram real? And it certainly is. And so we're getting more comfortable with our F2 values. In terms of F3, again, the use of shear wave has helped us decide whether we're dealing with an F3 or whether we're dealing with a fatty liver. So when we get this same appearance of the liver, quite bright but not cirrhotic, and we put a shear wave on and we're getting 11 as opposed to a low number of 6 or something lower, we think, oh yeah, we're actually dealing with a stiffer fibrotic liver as opposed to an attenuating liver that's soft, that's just non-alcoholic fatty liver disease. And we're getting more and more used to our F4. So as I said, we would probably get most of our patients tend to be F01 or F4 because they present at this stage. And we're getting used to the fact that with our really high numbers, we're getting wide, thick lines and numbers that are really up there, like 150, as opposed to a lot of our other patients where we're still getting high numbers. But look at these elastograms. It doesn't look like a red, stiff liver, but we know that we go back and we correlate these patients and we know they're cirrhotic. So you really do have to, almost like with colour Doppler, where you get varied appearances of stenoses or hemodynamic patterns, you have to apply the same to elastography. And my only advice really is that the more you do, the more comfortable you feel with them. So how are we comparing with the Fibrous Scan? Because we've had ethics approval to have a look at what our fibrosis scores are compared to the Fibrous Scan. And you can see that we're getting some differences at F2. But as we saw earlier on, we know that when it comes to 2D shear wave accuracy versus Fibrous Scan, that in fact we are more accurate. So we think, as you can see on this next chart, that even though we're often getting one fibrosis score difference, we think that we're actually possibly getting closer as the gold standard rather than the Fibrous Scan. So we're actually pretty happy with this. As you can see, out of 93 patients, we've got 80% of agreement where we're exactly the same in fibrosis scoring, and then there's just a few that we're out, but only 4 by 2 stages and only 1 by 3 stages. So we're pretty happy with where we're sitting at the moment. We've been doing some incidental work with elastography of the liver and looking at HCCs. And it's interesting because we know that with other areas, when you develop a malignancy, the thought process is that malignancies are stiffer than surrounding tissue. Well, of course, in a cirrhotic liver, it's the opposite. You've got a very stiff normal tissue and a softer lesion. So here we can see we've got the comparison of two lesions, two areas here. The actual HCC has got an a shear wave value of 4 meters a second, and the liver itself is 7.7. So it's interesting to use these tools. I'm not suggesting that if you get a, any lesion to put the shear wave on, and if it's not as stiff, you can say it's a malignancy, because it doesn't work like that. But it's just interesting to get your thought process around using it in other backgrounds. So this is how we use shear wave at Fiona Stanley. A patient presents for a chronic liver disease study or a liver ultrasound study. If they have HCV or hepatitis C, we use shear wave and we grade it. If they've got HCV and they've had treatment, we do a shear wave, but we don't actually quote a grade. If they've got any of these backgrounds, so chronic cardiac failure, hepatitis, cholestasis, or a raised transaminase flare, we don't use shear wave. And then for any other disease, even though we don't have a lot of studies, we know that when you look at all of the disease processes, including TE or Fibrous Scan, if a patient has a kilopascal value of less than 7, you're almost always dealing with a normal liver, and irrespective again of the unit or the background pathology, if someone has a kilopascal value of more than 13, you're almost always dealing with a cirrhotic liver. And we always do this in conjunction with the way the patient presents, what our chronic B mode factors are, vein wall irregularity, LADA, Dopplers, what our portal vein and collaterals are doing, and then our shear wave. So it really is a combined process. So what's next in this space? Well, we know that at the most recent European College of Radiology meeting in 2017 in Vienna, there was presentation of this table for using the Toshiba 2D shear wave for any disease process. And we hope that that work gets published soon because it will enable us to use it in any disease process. But going forward, we can be quite sure that if we're using 2D shear wave with hepatitis C patients, we can decide exactly what their fibrosis score is. We are good at saying whether patients have portal hypertension, irrespective of what disease process they have. We are able to use our propagation maps and our continuous shear wave to increase our operator confidence. We can start to collect data in other areas, and we are doing this at this institution, but we always use it in conjunction with other tools. And at this point, I'd just like to acknowledge the assistance of other Fiona Stanley hospital staff. So if I can just throw the conference out to questions.
Hi Marilyn, it's Claire here. There is one question. Can you put the reference slide back up, please? I believe that we're probably referring to the chart of values. Would that be correct?
The chart
the references. Values? Oh, Amanda, do you just want references? I believe she probably just wants the references.
Okay.
Okay.
Well,
perfect.
Yeah.
That's easy.
We've got the 3 pages of references, and then.
And Tanya. Oh, yep. Go for it, Marilyn.
Yep, Tanya.
Tanya asked a question probe? About, pediatric probe.
Tanya, well, we actually use our normal abdo probe, our C61, to do the pediatric elastography. But that's also because we do the elastography on our obese, we've got like an obesity clinic, and so those patients, unfortunately, do need the pediatric probe. And because we know that there's that sweet spot at 4 centimetres, and we're quite convinced that we don't get the variability, we like to use that same technique for the liver.
So,
Claire, I've just got one question from Amanda.
yeah.
Hang on, it says, we aren't getting history. How do we report this? So is that in terms of what their presenting disease process is?
That may be something that you might need to request from the referrers.
And also, Amanda's asked, if someone presents with just a request from an ARFI, do you just follow the final flow chart you put up? Is that, you mean the chronic liver chart? Oh, is this not? Oh, this one? Yes. At this point, if they're not specifically HCV, we haven't got the other data yet.
And there's also another question, Marilyn, do you record the weight of the patient?
No, I don't record the BMI, but what we do is we will say, because if your sweet spot 4 to 5 centimetres is less than a centimetre from the hepatic capsule, we will sometimes write that, but no, we're not collecting BMI information because the BMI doesn't always reflect if they've got abdo, if they haven't got, if they've necessarily got increased space between the probe and the liver.
Okay, great. And the final question was, should the 10 measurements for RFE be done at different spots?
Well, we don't use RFE. My understanding with RFE is that I don't think they do them at different spots, and certainly we would only change our region of interest for 2D shear wave if we thought that we were getting really bad standard deviations. Otherwise, we tend to use that same approach, maximise your B mode, make sure you don't see any vessels and you don't think you're getting standard deviations because you've got that big thick slice thickness, and then we would move. But otherwise, I don't think that you move it all over the place, no.